Hi all, welcome back. Mohammed ElMallah here with another cataract surgery video, full-length video, unedited, of a cataract surgery. We've started the case, we've done a paracentesis, we have placed a preservative-free lidocaine, and I think this is Visco to fill the anterior chamber. And then we're going to use 0.12 forceps to stabilize the globe and a 2.4 millimeter keratome blade to make our main incision. Then we will use a cystotome to start the Capsulorrhexis. Looks like I just placed a little bit more viscoat there. And then the cystotome will start the Capsulorrhexis, one continuous movement, raise the flap at the same time, and then we'll come in with Capsulorrhexis forceps. So important to size the Capsulorrhexis properly. We want to have some overlap over the optic edge for the IOL. And that's a continuous curvilinear Capsulorrhexis, no issues there. BSS on a hydrodissection cannula to perform hydrodissection. We see we've raised the anterior capsule there. We saw a triangle sign. And we've got, should have a good cortical cleaving hydrodissection here. I'm just orienting the sleeves of my phaco. And then I go in with the phaco probe. I do a Phaco Chop technique, my second instrument. We go into the nucleus with the phaco probe, and then we reach around and do a horizontal chop. And we've already got a nice rotation here, as you can tell. Just that single cortical cleaving hydrodissection fluid wave is enough to give us often a good rotation. So we split the first heminucleus into quadrants, and now the second heminucleus we're also going to split into quadrants. Very nice. So we've got 4 nice quadrants here. Now we can go ahead and start removing each quadrant. I use the same phaco mode throughout the entire procedure. I start out actually in quadrant removal mode. So here we are using the Alcon Centurion. We are doing torsional phaco, and we're doing intelligent phaco. So when it gets to 90% occlusion, then we get a little burst of longitudinal, so things keep moving and the piece keeps rotating. For this part, really, it's important to have pieces that are small enough that tumble. You want to see that nice tumbling motion. That's how you're going to get the most efficient phacoemulsification. So 2 quadrants left here. We rotate them and align them so the phaco probe can grab the pieces. We use our second instrument here to protect the posterior capsule. Probably don't have to do it quite this much with the fluidics on this machine, but I do feel better knowing that the second instrument is protecting the posterior capsule, especially when most importantly for the last quadrant. So here's the last quadrant, which I usually leave as the biggest quadrant, so it has the most space. I usually leave the biggest quadrant for last, so it has the most space to tumble. And I try to remove the part of the lens, the epinucleus, first as I phacoemulsify. But here we've left the epinuclear piece for last. The second instrument is protecting the posterior capsule. You can see the posterior capsule looks really nice and clear here. Not much cortex left. I always go in and polish the capsule. Sometimes I'll find little fragments there that I wasn't expecting to see. So just like right there, there is some cortical fragments there that I've removed with that Terry Squeegee, that silicone tip, that cannula that has a silicone tip. Provisc now into the capsular bag. I've started now injecting Provisc both to the right and the left of the wound, so there's no residual nuclear pieces. IOL, Alcon, IOL, also Clarion. And we're going in, and I use the IA to position the lens. We can see we've got good capsular overlap here with the Capsulorrhexis. I start out in viscoelastic mode, remove as much viscoelastic as quickly as possible. When the lens moves like that, you know you've gotten some of the viscoelastic from behind the lens as well. Since we're doing ProVisc, very little chance of retained viscoelastic. And now we switch to cortex mode, which has a lower aspiration rate, more control with the foot pedal, doesn't rise quite as quickly. And I can use that now to remove any remaining cortical material that may be there. It already looks pretty clean. At this stage, I may polish the underside of the anterior capsule, I may not. And I went there to see and try and grab any pieces that may be lurking at the paracentesis. For the main wound, we hydrate the anterior lip of the incision. And then here so what I'm doing here is I'm checking the fornices for any retained nuclear fragments. And we see there's just a little bit of viscoelastic there, which is really not a big deal. But I've actually stopped doing that part. I do that now with the ProVisc when I inflate the chamber. Okay, so it looks like we're getting ready to wrap up here. I feel the pressure may be a little bit high, so I let out a little bit of fluid there through the paracentesis. I'm happy with it now. We're going to check to make sure things are watertight. Let me know your feedback, you guys, in terms of how you do your cataract surgery, anything you like or don't like about this technique, or ways to improve it. And I hope you enjoyed this video. I hope you learned something. Thank you very much. And I hope you have a fantastic rest of the day.